friends, it's Miss Buck. I hope everybody has had a great spring break and you've all rested and rejuvenated a little bit. So we are going to be covering mechanical ventilation and ICU pulmonary disorders on Monday. So I wanted to go ahead and record this so that you guys could watch it and kind of do like last time and come in and do a big review and hit the high points and kind of give you a guideline of what you need to know for your exam. So without further ado, we're going to get into it. Make sure that if you have any questions that you kind of jot it down so you can ask me on Monday, or you can email me too, whichever works best. With it being the weekend, I just may not be checking my email as frequently, so just keep that in mind. And this hopefully will not be as complicated as hemodynamics was. This is a little bit more easy to kind of grasp and get your noggins around. All right, these are just our objectives. Oops, skipped one. Okay, so we're going to start off with VQ mismatches. But first, I kind of want to hit and do a little A&P review. Y'all know me with my little A&P reviews. So with our pulmonary system, we've got our upper airway, we've got our lower airway, and we've got our lungs, right? So our upper airway is going to consist of our nasal cavity and our pharynx, and it's going to filter. That's going to be its big job. So when we have artificial airways that are in place, those functions get bypassed, right? Because we're not breathing on our own. We've got something down our throat breathing for us, pushing oxygen into us and giving us our breath. So we bypass that nasal cavity and that pharynx. The lower airway is going to consist of our larynx, our trachea, right and left main stem bronchi, bronchioles, and alveoli. So with our lower airway, we get into what we call our bifurcation of that right and left main stem bronchi. So the bifurcation is going to be known as the carina. And this is going to be really important for us to know what that carina is, because when we start intubating patients, that ET tube, when we drop it, not us, but the provider, can sometimes go into a main stem bronchus or bronchi. So it's important that we know where that's at, because if we drop it into one of those main stems, we can very easily have problems. We can give too much pressure to one lung and it can cause a pneumo. We can not adequately oxygenate the other lung, and that becomes an issue. So there's just a lot of things that can arise from not being able to adequately perfuse and oxygenate. So when we drop those ET tubes, we want to be mindful of where that carina is and where that ET tube is in relation to the carina. So we're going to talk about that here in a little bit. I just wanted to go ahead and mention that. That is very important. It's usually 2 centimeters or so above the carina is where you want your ET tube, the tip of your ET tube, to sit. An ET tube is endotracheal tube. Okay, and then we have our lungs. So we've got our right and our left lung, obviously. And then, well, in most patients, unless they've had a lobectomy or had a lung taken out or whatever. Most normal people have 2 lungs. Our lungs are covered by pleura. So we've got 2 different pleura. We've got visceral and parietal. Our visceral pleura is going to be what covers our lung surfaces. And then the parietal pleura is what covers the internal surface. So visceral is going to be out, parietal is going to be in. Okay? So big thing here with our visceral and parietal pleuras, we've got pleural fluid that sits between these spaces, and it helps to lubricate and hold those 2 pleura together to create surface tension and keep our lungs up. So our lungs normally are at they're a negative pressure type system, and it's usually at about 5 centimeters of water is what that negative pressure sits in our lungs. So when we start having things like pneumonia happen, this disrupts that negative pressure system, and it can lead to things like pneumothoraxes, and that's when we have to have chest tubes put in to help get those lungs back up. Okay, so now we're going to move into VQ mismatches. All right, so VQ stands for ventilation and perfusion. So ventilation is obviously represented by the V. Q, for whatever reason, is perfusion. Don't know why it's not a P. I didn't make it up. So this diagram specifically demonstrates that continuum of ventilation and perfusion relationships. So on this diagram, like I said, ventilation is represented by V and perfusion is represented by Q. Okay? So ideally, each alveolus in the lung would receive the same amount of ventilation and blood flow. But in reality, ventilation and perfusion differ depending on the region of the lung. So the average normal adult will have about 4 liters per minute of ventilation that enters the lungs and about 5 liters per minute of blood that enters into that pulmonary capillary bed. So the exact ratio of ventilation and perfusion varies based on gravity and normal regional variations in distribution. So, like for example, every time you stand up or lay down, blood flow to the different parts of the lungs changes because of your gravity. Okay. And I also want us to think about the shape of our thorax. So gravity in that interpleural, or gravity in our interpleural pressure, are also going to impact ventilation, okay? So gas exchange is dependent upon the balance of, gas exchange is dependent upon the balance between ventilated areas of the lung and then that are receiving blood flow, okay? So the rate of ventilation usually equals the rate of perfusion, and that's what we get our VQ ratio. And it's usually 1.0. 1.0 is normal. So when we start having mismatches, so things aren't adding up, we're too high on one, too low on the other, we're not equal, okay? If ventilation exceeds, this is just an example, if ventilation exceeds perfusion or blood flow, the VQ ratio is normally greater than 1. And if it's less, so if ventilation is less than perfusion, then the ratio is less than 1, okay? So VQ mismatches can happen when we have things like pneumonia, like I said a minute ago, or pulmonary edema, basically when our airways become obstructed and inhibit ventilation, but perfusion is still normally normal. And on the flip side of that, when things like pulmonary embolisms occur, it's an obstruction, so we have perfusion that is not being adequately done or adequately like in our body. We're not perfusing normally. But ventilation is still relatively normal. So for this diagram specifically, this relationship, like I said, is kind of considered as a continuum. So on the far right is alveolar dead space, and this is an extreme at one end of the continuum, which shows ventilation without perfusion, okay? Okay, so I think I said right, and it's definitely on the left. Anyway, so this is going to show this little A. We can see perfusion, but we see blood flow, we see ventilation, but we see perfusion is blocked. So ventilation, we have ventilation without perfusion, okay? And then we have ventilation with some perfusion. This we've got normalcy, everything's happy-go-lucky, okay? And then over here on E, we have, so sorry guys, we have intrapulmonary shunting, which is perfusion without ventilation, okay? So we're pushing blood through, but we have no air. And then, like I said, an example of no perfusion is a PE because there's an obstruction. We're not perfusing, we're not pushing blood. And an example of no ventilation would be something like a pneumothorax or atelectasis or pneumonia or mucus plugging, something that's causing us to have an obstruction of the airway passage to not get like a airflow through. Okay, so perfusion, no perfusion, think blockage in the blood. Okay, no ventilation, we're not pushing air. So we're either plugged off, we've got something down, or yeah, that's basically it. Something's either plugged off or we got something down. Okay, and this is just another little diagram that I have for you guys. And another diagram. Okay, so next we are going to talk about what our waveforms should look like on our vents. Okay, so we can have a sudden loss of waveform, and this is going to be due to either an ET tube that becomes disconnected, dislodged, kinked, or obstructed, or we can have a loss of circulatory function. We can have bronchospasms, and they kind of look like a little shark fin. I don't know why. Every time I literally hear shark or shark fin, I literally think of, is it Nemo shark bait? Hoo ha ha. That's literally what I think of when I think of bronchospasms and what they look like on a vent, because I think of sharks. Anyway, so sorry. But this can be because of asthma, COPD. Something is causing us to have a bronchospasm. So we see this little shark fin model. So we can have a decreasing end-tidal CO2. This can be because we've got a cuff leak, the tubes in our hypopharynx, or there can be a partial obstruction. We've got hypoventilation. So we see we're not really getting a whole lot of oxygen to us. And then hyperventilation, we're getting too much oxygen, okay? CPR assessment, we want to attempt to maintain a minimum of 10 millimeters of mercury. Sometimes that's not always attainable, but we try. And then we can have a decreased end-tidal CO2, and this can be because of apnea or sedation. And then a sudden increase in end-tidal CO2, return of ROS, so return of spontaneous circulation. So when we're coding a patient actively, a lot of the times we will have an end-tidal CO2 monitor on the end of their ET tube or on their ET tube, and respiratory is 9 times out of 10 the person who handles all of this, and we don't ever really see it as a nurse because respiratory therapists are the GOAT. They're great. They're literally your best friend in an ICU. But when we see that sudden increase in end-tidal CO2, it means that the patient is actively breathing again. So it's that return of spontaneous circulation. They're circulating again. So you can see right here, CPR, it's a lot lower because they're not pumping normally. We're pumping for them. And then down here, boom, we spike because they have circulation back. Okay. Next is the oxyhemoglobin dissociation curve. So this can be a little confusing, and I don't want it to be confusing to you guys. So this, I'm going to start with this. This is a little picture, okay? So we can see we've got our oxygen saturation percents over here, and then down here we have our PaO2s, okay? Remember, PaO2 normal is 80 to 100, or 80-ish to 100, okay? And then our oxygen saturation percents, okay? So we can have a shift to the left over here, or we can have shifts to the right, okay? Or we can just be happy-go-lucky in the middle. So factors that shift the curve to the left are going to include an increase in pH, a decrease in CO2, decrease in temperature, or we can have decreases, so we can have hypothyroidism, a hexokinase deficiency. We can have bank blood, some congenital problems can also cause shifts. And then we can have factors that shift curves to the right. So a decrease in pH, an increase in CO2, an increase in temperature, and then hyperthyroidism, anemia, chronic hypoxemia, high altitude, congenital heart disease, and then some other congenital abnormalities can cause that. So we can see down here, the curve is shifted to the left because of the hemoglobin's increased affinity for oxygen. Okay, the standard is B, like I said. So the standard oxyhemoglobin dissociation curve is B. B is our happy-go-lucky, medium, everything's great, hunky-dory. C is that shift to the right, so right here, okay, because of the hemoglobin's decreased affinity for oxygen. Okay, does that make sense? So if we've got, let's take anemia for example, okay? We know that oxygen is carried on the hemoglobin in our blood, right? So if we're anemic, we have a decreased affinity for, our hemoglobin has a decreased affinity for oxygen because we don't have as much. Okay, does that make sense? All right. So that horizontal curve basically just shows PaO2 above 60 results in minimum changes in oxygen saturation, which helps to protect the body and allows for high saturations with large decreases in PaO2. Okay. And then we have the vertical curve, which shows that PaO2 below 60 and results in significant decreases in oxygen saturation, and that allows for tissues to extract large amounts of O2 with only small decreases in PaO2. Okay. So like I said a minute ago, shifts to the right causes, these are your big causes right here. Decrease in pH, increased PCO2, hyperthermia, and then the chronic hypoxemia. Okay, so let me go back to that. Okay, shifts to the right. Right here, shifts to the left, right here. Okay, so shifts to the right are a little bit more difficult to pick up at the lung level, but easier to drop off or unload at the tissue level. And then on the opposite side, shifts to the left are a little bit easier to pick up at the lung level and more difficult to drop off or unload at the tissue level. So it's just the opposite. And then I highly recommend watching this little video right here because it explains it super, super great. But basically, I need you guys to know your factors that cause the shifts, and basically that a shift to the left is because of the hemoglobin's increased affinity for oxygen, and then a shift to the right is because of hemoglobin's decreased affinity for oxygen, and this is what causes it. Okay, so I'm also going to post, Mr. Harmon has a super, super, super great YouTube video that he talks about ABGs and when we start getting differences and what we do with our vents and stuff like that. It's about a 15 to 20 minute video. So I'll post that. I need you guys to watch that too because he's going to really break down your ABGs and everything really, really well. So I know that he's already taught you guys ABGs, but this is just a little bit of a reminder. So pH, our normal is 7.35 to 7.45, okay? Anything below that is acidotic. Anything above that is alkalotic. Our normal PaO2, like I said a minute ago, is about 80 to 100. Normal CO2 or PaCO2 is 35 to 45. And remember, this is opposite. Respiratory is opposite, okay, when you're doing ABGs. So 7.35 to 7.45 is acidotic below 7.35, and 7.45 is alkalotic. But when you're doing respiratory and CO2, remember 45, anything above that is going to be acidotic, and anything below that, or below 35, is going to be alkalotic. So it's respiratory opposite. When I was a student and always wrote down my ABGs, I would write it down, but flip and put like, so I'd write down like 7.35 to 7.45. And then I would put 45 under 7.35 and 35 under 7.45. And then I would write acidosis and alkalosis so that I knew which one was what. And then our normal CO should be, CO3's bicarb is 22 to 26. So anything above 26 is alkalotic. Anything below 22 is acidotic. And with your ABGs and stuff, we'll kind of go through. I really think once you watch his YouTube video, you'll know what we do with our vent settings and stuff a little bit better, because he goes through like multiple examples of ABGs and what you should do if we increase our rates, if we give bicarb, if we decrease our rates, and things like that. So I'm not going to get into that too much here because you've got about a 15 to 20 minute video to watch with him, but we'll talk about it on Monday. Okay, airways. So we've got a couple different types of airways that we can use. We can use oral, nasal, or tracheal. Honestly, nasal is really only going to be in like trauma type setting. I'm not going to say I've never, because I have like once or twice put in a nasal trumpet. But we just don't use them as frequently, because if somebody's having trouble oxygenating, then we are more than likely going to intubate them with an ET tube. Most of the time, the rule of thumb is if we can't get somebody extubated, meaning we can't get that ET tube pulled out and get them breathing on their own within about 2 weeks, then we typically start talking about putting in trachs. And really the reason for that is because leaving an ET tube any longer than what it needs to be, we start running the risk of having things erode, and we're going to erode through things, and it's just going to create a lot of issues, because that's not where it's supposed to be. It's technically a foreign object in the body. So we start looking at putting in tracheostomies and going from there. Okay, so this is what your normal ET tube looks like. So it's inflated at the bottom, so it's got a cuff or a balloon, bulb, whatever you want to call it. And this is the little port that we put air into. Honestly, you as the nurse should never really be the one to put air in this, because you can blow these very, very easily if you're not careful and you don't have a way to measure the cuff pressure. So basically, respiratory is the one who handles this. One of my husband's cousins is a respiratory therapist, and she hates when people mess with her tubes. She's like, don't touch my tubes, I don't touch your drips. So sometimes, depending on your respiratory therapist, especially if you work with them all the time and you guys have a good rapport with each other, they're okay with you inflating it just 1 mil or so, but 1 to 2 mils. But anything lower than that or more than that, you just need to go ahead and call them. So rule of thumb, especially if you're a new nurse, just don't touch your bulb, call respiratory. Because most of the time as nurses at bedside, we don't have a way to monitor the pressure cuff. And if we blow a cuff or a bulb, we got to re-intubate the patient. And a lot of the times that's a pain and a half, because once you've intubated them, you've caused trauma to that airway. So there's already going to be probably some swelling, some irritation, and they're going to be more difficult to intubate than they already were the first time. So just call respiratory. When in doubt, call respiratory. They're your BFFs. So this is the tip of the cuff, or the tip of the tube, and this is what should be 2-ish centimeters above the carina on an x-ray to know that it's in the right spot. And then this is where we connect our patient to the vent. Okay, that's where our little vent tube is connected. And a lot of the times there's it's called inline suction, will be hooked to the vent and it comes out straight, whereas the vent, like breathing tube, airway tube, goes kind of to the side. That will come straight out, and there's a line that you push and it goes all the way down, and you basically just pull it back, and there's a little button you press and it suctions and clears their airway out. Once we do ICU rotations this summer, I'll show you guys, because I'm sure that we'll have vents and stuff. Okay, so, oh, yep, I said I was making sure my little notes that I didn't miss anything. So 2 centimeters above the carina. When we intubate our patients, we want to mark. You see these little markings right here? So we want to make sure that we mark where our patient's ET tube is. And a lot of the times, most of the time, it's going to be either at the teeth. A lot of the time, that's where we mark it at, is at the teeth. But you'll also see it marked at the lips. So it's, you know, I don't know, 22 at the lip, 22 centimeters at the lip, or whatever, or 22 centimeters at the teeth. But it just depends, and always make sure that when you're documenting, when you come onto shift, you should always look to see where your ET tube is and see where it was documented at last. And honestly, if your off-going nurse is with you, look at that together, because they're going to be able to probably tell you, oh, hey, that's not in the right spot, like that's moved. And if that's the case, you need to get a chest x-ray and make sure that it's still about 2 centimeters above the carina and hasn't either pushed down or pulled up to where you're either going to need a provider to come and push it down a little bit, or a respiratory therapist to push it down a little bit, or pull it back. Because too far up or too far down are going to be problematic either way. Okay. So this is basically just a little guide of the intubation process. So we can see our glottis here. This looks like a Mac blade to me. We have a Mac blade and a Miller blade, I'm pretty sure. Mac blades really are the ones that I see used, and they're curved. It just kind of helps with the anatomy a little bit more to have it curved and push things back. Miller blades are straight. And then we will see a variety kind of these used, different shapes, different sizes. The provider or respiratory is going to know what size the patient needs. When we intubate somebody, we want them supine with their neck flexed and their head slightly extended, kind of like in the sniffing position. And this just helps open up so that they can get that tube down in the right spot. Okay, so the little acronym SLOPE. So we want suction, syringe, stethoscope, sedation, and a stylet. Most of the time, like I said, your respiratory is going to have the stylets. They have an intubation cart and all this other stuff that they just bring. Lubricant, laryngoscope, we need oxygen, patient positioning and pressure, and then end-tidal or ET tube and our end-tidal CO2. So that end-tidal CO2 is going to tell us if we're in the right spot or not. Suction, obviously, because if they have a bunch of secretions in their airway, we need to get that out. We need a syringe to help. We got to use that to inflate the bulb or the cuff of the ET tube. Stethoscope to listen, make sure we're in the right spot. Anytime you intubate a patient, you should always have sedation. The only time that they really should not be on sedation is whenever they are doing breathing trials and we're trying to see if they can breathe on their own for us to get them extubated. But if they are being intubated or they are currently intubated, we're not planning to extubate them, they should always have some type of sedation. And then lubricants, obviously, just to help slide the ET tube down a little bit easier. And then laryngoscope, like I said, your respiratory therapist is usually going to be the one to have this. Oxygen should be in your room if you're in a hospital. Make sure you're positioning them right. You got a pressure good. And then the ET tube, your respiratory therapist should have that, and the end-tidal CO2 monitor. So this is just a little example of, we call this the glottoscope. So you can see it's got a little camera up here. So if people are harder intubations, it lets the provider see exactly where they are when they're putting that tube down, and just makes things a little bit smoother and a little bit easier on the patient whenever we're doing this. So when we're intubating those patients, we're looking for this. These are the vocal cords, and that is where they're going to put that ET tube and pass that ET tube through. and then push it down to however far they have measured and secure it. Okay, so this is our end-tidal CO2 monitor, or detector monitor, however you want to say it. So this is what's going to be attached to the end, so you can see right here. It's attached to the end of that that ET tube to help detect CO2 to make sure that we're in the right spot. So basically, normal end-tidal CO2 values average 2 to 5 millimeters of mercury less than the PaCO2 in individuals with normal lung and cardiac function. So each time like that we take an ABG, our end-tidal CO2 value should also be noted. So end-tidal CO2 is subtracted from the PaCO2, which gives us an index that we know as the PaCO2 EtCO2 gradient. It's basically just a gradient that we use. So that gradient is used to estimate the severity of pulmonary disease, and it helps us to determine the baseline correlation between that end-tidal CO2 and that PaCO2. So, for example, if a blood gas shows us that the PaCO2 is 40 millimeters of mercury, and then we look at the end-tidal CO2, and we see that it's 36 millimeters of mercury, then that gradient is +4, which is within that normal range of 2 to 5, right? Okay. So on the opposite side of that, if we have a PaCO2 of 56 and then our end-tidal CO2 is 32, then that gradient, the difference is what we look at, okay? That difference is 24. And that is what's going to tell us that there's usually like significant areas of the lung that are ventilated but not perfused, so there's dead space. And that affects the exchange of carbon dioxide at that alveolar level. An example of that would be that significant dead space would be that pulmonary embolism like we talked about earlier. So, therapies are targeted to improve matching of the ventilation to perfusion in the lungs when we look at stuff like this, if there's a massive gap or things that need to be corrected. Okay, so now we're going to talk about cuff pressures. I kind of talked about them just briefly earlier. So it's best to keep that cuff inflated to help minimize aspiration. So that cuff is going to keep things blocked from going into our airway, or it's going to help keep things blocked. So basically, if our patient throws up or something like that, which is possible because I have had that happen before, while my patient's intubated, then I freaked out that they were going to have aspiration pneumonia and it was just going to be a disaster. They were fine. Basically, the patient ended up having a bowel obstruction and he was on tube feeds and everything was going down. I was checking residual, which is why it's important to check residual. I was checking residual every 3 or 4 hours, was never getting back more than about 20 to 30. Really wasn't anything crazy. Was normal, so I pushed it back. But then I guess it got, the way that the doctor explained it to me was it got down to the blockage and then everything started backing up. And then that's when everything just kind of came back up. So anyway, that's why it's important to keep our cuffs inflated, because the patient ended up being okay. He had a little bit of aspiration, but nothing major. And he was already on antibiotics for an infection that covered the aspiration pneumonia, so he was fine. But that is why it's important. Cuff pressure should normally be 20 to 25 millimeters of mercury. Like I said, normally you're not going to be the person to know what that cuff pressure is, but respiratory rounds every 3 or 4 hours and checks those. They check them at the beginning of the shift, kind of in the middle of the shift, and then usually towards the end of the shift. And then we should be checking them at least every 6 to 8 hours, or respiratory should be checking them. But like I said, normally it's about every 4-ish or so, 4 to 6. Okay. So you as the nurse, when we are caring for a patient who is intubated and on an ET tube, our duties are to verify placement by auscultation first. So we want to listen to lung sounds on both sides, make sure we hear lung sounds whenever we're giving breaths to the patient or whenever respiratory is giving breaths to the patient. Verify placement by that end tidal CO2. And then obviously the only for surefire way to know that that is in the correct spot is with an x-ray. We want to secure the tube. Most of the time, respiratory is also really good about securing it because they keep the ET tube holders. And if you ever need a new one, if yours gets skunky, it's just not sticking very well, they can always change it out. We want to monitor the position of that tube, suction when needed, watch for skin breakdown. Sometimes if those patients are really, really fragile with their skin, or they just can't, they've been on it for a really long time with the vent, then those little pads will start kind of breaking their little cheekbone skin area down. So we kind of want to monitor for that. And then we want to prevent dislodgement. So with that, patients can self-extubate. They can be little Houdinis. I've had that happen a couple of times. And it's been when I've been like in my other patient's room, and somehow they get out of their restraints. So obviously your restraints should never be too tight, but they should be tight enough that your patient can't get out of them. One of mine was a patient who was detoxing off of drugs and just had superhuman strength. The other one, I'm really not sure what happened. She was really, really tiny, so I'm thinking she may have just like finagled and slipped out of one, and she just pulled that thing right out. When that happens, that cuff is obviously still inflated, so that's kind of a problem. It's just like if somebody pulls a Foley catheter out with the bulb intact, same concept with your airway. So it can cause a lot of trauma, a lot of bleeding. So we really, really, really want to prevent that. So these patients are always in some kind of restraint to where they can't self-extubate. And then we want to monitor the cuff pressures, and then always, always, always have an ambu bag at bedside. In an ICU, this is going to be pretty standard. It's usually in a bag hanging on the vent or in a bag hanging on the wall. But if your patient plugs off or they start to code, you've got to take them off of that vent, and you've got to start bagging them because we can't leave them on the vent. Ambu bags are great for trying to bust up a plug, and respiratory is usually the one who does this. They'll put a little bit of water down that ET tube, just enough to kind of like lavage it, just to break that clot up, and patients usually are fine after that. But if you automatically like just start seeing a drop in your O2 and the patient's, bucking the vent and all this other stuff, they very well may have plugged off. So call respiratory, get the ambu bag, and, we can go from there. Okay, I kind of already talked about end tidal CO2. It's just the measurement of that exhaled carbon dioxide. So respiratory baseline, we have the expiratory stroke, plateau. This is where that end tidal CO2 is measured, and then that inspiratory downstroke. Okay. Then we have endotracheal tube suctioning. So hypoxemia is obviously an issue. So we want to make sure to give O2 breaths, is what we call it on the vent. And respiratory usually attaches, this is that inline suction that I was talking about. So this catheter is wrapped in this little sheath which keeps this sterile. So you don't have to have sterile gloves on or anything when it comes to this. And then this is the little suction port that you press that actually initiates the suction. And then it's connected to a suction canister on the wall right here to help suction. So this is that T-piece where it's connected to the vent. Like I said, this comes straight off. The vent portion comes straight out to the side. This is where they can lavage if needed, and we basically just pop this off, put the ambu bag on, and they can instill sterile water, sterile saline into here and lavage and try to bust up plugs and stuff. If this sheath ever gets a hole in it or anything like that, it needs to be replaced because, like I said, this is sterile. You're pushing this down into their lung. So if you're pushing things that are not sterile down into somebody's lung, you're probably going to give them a lung infection at some point. So, rule of thumb, inspect this every time you suction. If they've been on there for a really long time, they just get wear and tear on them, so they just have to be replaced. We don't ever want to suction more than 3 times, no more than 10 seconds, 10 to 15 seconds, and no more than 3 times. Make sure you're giving hyperoxygenated breaths, 100% O2. If you know that they're going to desat really quick, I usually leave them on 100% O2 for a minute or two, really get that oxygen up, and then suction them, and then sometimes I just have to leave them at 100% and then wean them back down after. So patients like that, if you know that they're going to desat and they just don't tolerate it very well, you may have to baby them a little bit more when it comes to their oxygen, and then wean down their oxygen a little bit more after. Okay. So our ET tube complications. So for insertion, I've kind of already talked about trauma. With nasal trumpets, and you can technically put an ET tube down somebody's like nose. I think I've never seen it done, but I think that that's a thing. But regardless, if you're putting any kind of advanced airway into somebody's oral or nasal cavity, there's always the risk for trauma. Pharyngeal and hypopharyngeal trauma as well, so down in your throat. And then if they don't have adequate paralytics on board to help deaden all of their gag reflexes and stuff, then we can cause vomiting, and with that can cause aspiration. And then depending on the person, it can sometimes make them bagel down. There's just cardiac arrest is always a complication too. So while in place, nasal and oral inflammation and ulceration. So like I said earlier with ET tubes, when patients are on them for about 2 weeks or so, if we can't get them off, we usually start talking about putting in a trach, just because it starts that tube starts eroding and causing a lot of inflammation and ulcers. They can get sinusitis and otitis if it's a nasal advanced airway, and then obviously laryngeal and tracheal injuries, and then tube obstructions and displacement. So those plug offs and accidentally getting pulled out, or patients self-extubating, things like that. Okay, so with these patients, when they are intubated, we always want to make sure that we are doing our due diligence with providing really good oral care. So most of the time it's every 2 hours. I know both hospitals here in town, NEA and St. B, require every 2 hours. And it's usually like a little oral care kit. They're disposable, but it hangs on the vent or on the patient's wall beside the vent, somewhere in the room with the patient, because they are extremely susceptible to developing ventilator-acquired pneumonia, or VAP. And it's because of the microaspiration of that subglottic secretions that they produce. Those secretions develop around the cuff, and then in critically ill patients, they have that increased amount of bacteria, and they're often more resistant bacteria that they have. So we just really want to be diligent with providing oral hygiene to help reduce the risk of them developing ventilator-assisted or ventilator-acquired pneumonia. Okay, this is just a cute little thing that I saw. So view, we want to monitor airway, ABGs, and respiratory status. E, we want to elevate the head of the bed 30 degrees, and then have our equipment at bedside, our ambu bag, O2, and our suction. I haven't mentioned this before, but it's always important that we keep these patients at least at a 30-degree head of bed or higher. Simply for the fact because if they're laying down any further, then that causes an increased risk for aspiration. And we just don't want that, because that's going to cause a lot of problems. So then we want to note and document our ventilator settings hourly, or at least when respiratory comes around. If you know that the settings haven't been changed and respiratory hasn't come around, that's one thing, but at least, you need to keep a check on it and make sure that things aren't changing. Most of the time, respiratory is really good about if they're going to change something, they'll let you know. Providers, however, are really bad. They're sneaky. They are little Houdinis. So they will go in and change your rate, change your O2, your PEEP, tidal volume, whatever, and walk out of the room and not say a daggum thing to you. And then you walk in, you're like, when the heck did that happen? And you've probably been in your other patient's room or something. So just always keep a note and just a check on that. Because if something happens and, ultimately it is your responsibility to know what your settings and stuff are. We want to notice any kind of gastrointestinal complications like stress ulcers, anything like that, nutritional needs. Most of the time, if these patients are going to be on a vent for a hot minute, we'll start them on tube feeds or they'll be on TPN depending on if they can't have tube feeds. And then take note of our settings and document any alarms. So we haven't talked about low versus high pressure alarms. So low is going to probably be a leak. We're losing volume. So low pressure alarms indicate low exhaled volume from a cuff leak, a disconnection, or a tube displacement. If we have a high pressure alarm, then we're dry, okay? So high pressure alarms indicate excess secretions, biting on the tube, kinks, coughing, something isn't there's too much pressure and it can't push through. Does that make sense? Too much pressure can't push through, high. So think your plugs, biting, kinking, coughing, things like that. Low pressure is going to be there's not enough volume being pushed through, so it's a low pressure alarm. So we've got a leak somewhere, something's disconnected, a tube's displaced, etc. And then apnea alarms, the vent doesn't detect spontaneous respirations. So this is going to be important, and we'll talk about settings here in just a minute. But this is going to be important if your patient's like on a CPAP trial, if they can't initiate their own breath and spontaneously breathe on their own, then this alarm is going to sound because they're not breathing by themselves. And then we want to suction our tracheal tube. Note the color, the amount. You probably, if it's a closed system, aren't going to see odor secretions unless it's coming out of their oral cavity. And then position to promote mobility of secretions, so that head of the bed at 30 degrees. Self-protection if needed. It's always needed. So soft wrist restraints per the healthcare provider's order. Okay. So if we have an obstruction, there's biting, kinking, secretions, foreign body. With biting, we can put bite blocks in. We can sedate them if they've got secretion, suction. Sometimes they need some humidity, and most of the time the vents will have humidity built into it. It's like just a little container. But if those start running low, they need changed out. We need to replace them. And then displacement, so movement, traction, or self-extubation. We want to make sure that our ET tube is secured, patient's restrained, sedated, and it's only about 2 inches about the lip, and then support the tubing and replace it if needed. Fistulas and stenosis, so this is pressure leading to necrosis. So from, like I've said, that cuff inflation, and then we want to monitor that cuff pressure, and then they may need a tracheostomy. Skin breakdown, that tube holder, they should reposition the tube on the patient every 4 to 6 hours or so. It's got a little clip that you can just move it from side to side, so that kind of helps decrease the risk of getting ulcerations and stuff in their mouth, and then should help skin breakdown as well because it's not just sitting on their lip in the same spot 24/7. So loosen tube holder. The tube holder itself should be changed at least every 24 hours, and then change the sides of the ET tube. So this usually, the sides of the ET tube is usually done once a shift. They usually do it twice a day. And then we inspect our skin every 8 hours or more often if needed. And then obviously if we're suctioning and all that good stuff, maintain sterile technique. Okay. So this is that oral care protocol, so VAP prevention like I was talking about earlier. We want to rinse or swab with chlorhexidine every 12 hours. So a lot of times it comes in like a little cup, or some of the oral care kits automatically have chlorhexidine built into them. So it just kind of depends on your facility and what they have, but it's not anything too crazy, but it needs to be done at least once a shift to help reduce all that bad bacteria and stuff in the mouth. Okay, so tracheostomies. So basically this, and I know that we talked about this summer, and I did trach care competencies with you guys, but there's a couple different types. We can have a cuffed, a non-cuffed. Remember, this little obturator is the thing that always stays at the bedside with the patient. This is going to be, if it's a cuffed, it's going to have a little balloon that we use to inflate it. And then it's got that inner cannula that can come out. And if you ever lose your airway, always make sure that you have your obturator at the bedside, because that's what's going to keep your airway open until you can get that tube put back in. All right, so long term, if a patient's going to need to be on a vent, if they're going to go home on a vent, any kind of oxygen, anything like that, this is the method preferred because of many reasons. So a trach tube, basically it's preferred because it avoids your oral, your nasal, pharyngeal, and laryngeal complications that are all associated with an ET tube. So since the tube is shorter and it's less curved, sometimes it's even a little bit wider than an ET tube. An ET tube is more like resistant to airflow, and it just makes it a little bit harder to breathe. These are a little bit easier. And it's easier to remove secretions, and it increases patients' comfort too, because they can talk, they can eat, walk, and weaning off the ventilator may be a little bit easier. So depending on what type of trach they have is going to depend on if they can talk and eat and all that good stuff. But they can have like those little valve caps and stuff like that, a talking valve. I have had patients with those before. And they can communicate. It's just a little bit easier. You obviously can't do that if you have something in your mouth, down your throat. So, alright, so this is just a little diagram that shows you where the trach sits. So here is where the opening is, and then it curves down into the trachea, and then your lungs, left and right main stem are right here. Suctioning is pretty similar. Activity is obviously going to mobilize secretions, so if they're up walking around and doing stuff, it's obviously going to help move secretions and stuff out a little bit more. It's still a sterile procedure, just like we talked about this summer. Still usually a closed system for an inline suction. We really only want to suction when necessary, because the more you suction, the more secretions you're going to make. And then we always want to check baseline vitals before, during, and after. Increase the oxygen if we need to. Don't suction more than 10 seconds, so we still want to hyperoxygenate them prior. And then rest before reattempt. So still, I wouldn't suction more than 3 times. Okay, so the cuff pressures should not exceed capillary filling pressures of the trachea. So usually it's about 25 to 20 centimeters or 25 centimeters of water, or about 20 millimeters of mercury or less. We want to make sure there's an adequate seal for positive pressure ventilation and PEEP, and then prevent aspiration of large particles like urbanot liquids. Make sure that we're monitoring for low pressure and high volume cuffs when used. Look for leaks in the cuff or the pilot balloon valve that requires it to be replaced. Measure your cuff pressures, and don't routinely deflate because of risk of aspiration. If they're cuffed and they need to stay cuffed, there's obviously a reason. Don't deflate it and uncuff it just because. So still really the same concepts as an ET tube. All right, and this, I don't know that we've had a little picture like this before, but this is what they use to test the cuff pressures. And respiratory should have these. So 20 to 25 millimeters. It's not routinely deflated. Should still be checked about every 6 to 8 hours. Okay. All right, so mechanical ventilation. So airway intervention, intubation, and the reasons for the use of it could be from acute distress, respiratory distress, surgery, post-surgery overdoses, the patient needs sedated, or maybe we've got some kind of head trauma. Those are just a few reasons. All right, so different types of ventilators. We have negative and positive pressure. So negative pressure is applied externally to the patient, and it decreases the atmospheric pressure surrounding the thorax to initiate inspiration. Positive pressure uses a mechanical drive mechanism to force air into the patient's lung through an ET tube or a tracheostomy tube. And then we have different types of modes, volume, and pressure. Okay, so our traditional modes are going to be assist control. This is going to be the most common that you see on just a regular intubated patient. And you'll often hear it called AC for assist control. So this is volume cycled. So all breaths are mandatory, and it's triggered from either the patient or the machine. SIMV is also volume cycled, but there is a set minimum rate and a tidal volume. So the patient is able to breathe spontaneously between mandatory breaths. Whereas AC, all breaths are mandatory. So that patient is going to get every single breath regardless, because the machine's either going to give it or the patient is going to take the breath themselves. But they have to take every single breath. SIMV is going to be, there's a minimum, so like 12, like a rate of 12. Or 14 or 16 or whatever the rate may be. So we have a set minimum rate and a tidal volume. And tidal volume is based off of, the patient's weight, height, things like that, and it's calculated, and usually respiratory is the one who calculates this. But SIMV is going to be a set rate and a set tidal volume that are minimum that has to be given. So the patient can breathe spontaneously between mandatory breaths, so they can breathe like over the vent, I guess, is how you would say that. And then we have spontaneous, which is CPAP or PSV. I really have only ever heard it called CPAP. So all breathing is determined by the patient, and then there's no trigger or breathing mode offered by the vent. So this is where we do a CPAP trial. This is when we use this to determine if the patient is able to be extubated. Okay. So CMV, continuous mandatory ventilation, is really not super common today. So basically with this, the ventilator takes control over your breathing. We enter a set tidal volume and a set respiratory rate, and then any attempt to breathe over the vent by the patient is ignored. So this is appropriate if a patient is paralyzed due to meds, or the patient will never make an inspiratory effort. So maybe people who have like brainstem involvement or brain injuries who can't ever breathe on their own ever again. VC, volume control or assist control, I really only ever heard or hear it called assist control. There's a set tidal volume and respiratory rate for the patient, but spontaneous breaths above the set respiratory rate will receive the same tidal volume delivery that is set. So basically, the patient receives a controlled breath with controlled amount of volume for a set number of breaths. If the patient is breathing greater than the set number of breaths, each additional breath will also still be controlled by the same amount of volume. So they still get a set amount, but if they breathe over, they're still going to get that volume assist as well. And then we have PC, AC, which is the ventilator. So this is pressure control, assist control, and the other one is volume control, assist control. The ventilator with PC-AC is still taking complete control over the patient's breathing. But the key difference between the VC and the PC is how that breath is delivered. So volume control is set to a certain tidal volume to be delivered with each breath as the peak inspiratory pressure varies. Then we have the pressure control, which has a set peak inspiratory pressure with each breath and volume that will vary. So volumes will vary and be lower for like overweight pneumonia patients versus a healthy young non-smoker. The main advantage to this mode is safety, and it decreases the chances of barotrauma. So more careful monitoring, it's a more careful monitoring process because as lung compliance improves or doesn't improve, volumes will change and so will the overall benefits. Okay, then we have the SIMV, which is the most common. Honestly, I've seen SIMV and AC, really the two big ones that are used. Control does not appear in title. Patients take control over their breathing. So breaths and ventilation is delivered when the patient initiates that spontaneous breath. So the vent just supports the breath and the patient is taking or using the same settings as discussed before. So this just lets the patients drive the volume and the length and depth of the breath. And then pressure support is that PSV is no set respiratory rate. All breaths are spontaneous. No machine breaths are required. PEEP is the only pressure that remains in the circuit upon exhalation. And then this is just a little thing that I found. So we have controlled breath, which is no work. Ventilator does all the work. Assisted breath, the patient starts the work, then the ventilator takes over the work. And a supported breath, they're able to do some or most of the work, and the ventilator assists to finish the work, so i.e. pressure support. Okay, so this is an example of what SIMV looks like. So the patient receives periodic positive pressure breaths from the ventilator at a set rate and a preset volume. The patient can breathe unassisted and spontaneously without any additional volume needed. When a patient is able to breathe spontaneously, spontaneous efforts will be synchronized with the timing of the mandatory vent breaths and coordinated that way. So this was once considered the weaning mode, I guess, but clinical studies really haven't been conclusive regarding decreased time weaning. So SIMV could possibly contribute to respiratory muscle fatigue when the patient has a high respiratory rate and increased work of breathing. And then this is assist control. So this can be volume or pressure targets like we talked about. The rate is set on the machine and the patient will receive the amount of breaths per second at a set volume or per minute at a set volume. If the patient initiates additional breath, then the ventilator, like I said earlier, will still give that volume as well. So pressure control, a preset pressure limit delivers volume variable depending on the patient's compliance. The pros to this is airway pressure is limited, which prevents damage to the alveoli. The cons really is if the resistance rises or compliance falls in the patient's airway or chest wall, then that set pressure limit remains, but the delivered tidal volume falls. Okay, so then we have pressure regulated volume control. So this combines the best of two modes of ventilation. So volume control and pressure control. It's delivered over a set time to a set target volume, and there's a constant pressure applied throughout inspiration, regardless of whether breath is a controlled breath or an assist breath. Each breath is a PRVC, or a pressure regulated volume control, and the ventilator adjusts pressure from breath to breath as airway resistance and compliance change. Okay, so we've got pressure support, PEEP, CPAP, and high frequency. So pressure support ventilation is a pressure targeted mode requiring the patient to trigger every breath. We don't set a machine rate, so the absence of patient effort, with the patient not putting in effort, then the ventilator is not going to deliver a breath. So with this mode, it gives the patient more freedom with breathing. When the ventilator senses an inspiratory breath, dependent on the trigger sensitivity that's been set, it responds by delivering a gas flow with raises in the pressure in the airways. This has been shown to reduce the work of breathing and oxygen consumption, so it's become a highly useful adjunct, particularly in stable vent patients. All right, then we have CPAP. You guys have probably all seen these. We can have this as like the little nasal or face. These are the most common ones used in the hospital. These ones are like your home CPAPs. And then you can have a vent setting on a CPAP. So CPAP is associated with only spontaneous breathing and no positive breaths are delivered. So the airway pressure is very similar to spontaneous breathing, but the lows and highs may not be noticeable. So CPAP is a form of ventilatory support that is simply PEEP delivered to a patient who is spontaneously breathing. No machine breaths are delivered. So both CPAP and PEEP increase and help to prevent that collapse of the alveoli. It's the most often used method when we're weaning patients. This can be delivered, like I said, via either a mechanical ventilator or a separate device. And it can also be used or required during mobility activities. CPAPs can be disconnected for short periods of time during ambulation. And then CPAPs during physical therapy interventions may enhance a patient's tolerance, comfort, and compliance. If somebody's going to get out of breath really, really easy and a regular nasal cannula is just not cutting it, then we may be able to put them on a CPAP for a minute and try to get them through therapy if they really, really need it. So we have invasive versus non-invasive. That invasive is going to be on the vent. Non-invasive is going to be just like your mask or your nose piece. So pressure is the same throughout inspiratory and expiratory phases. So a setting example would be FiO2 of 40%. So they're being delivered 40% of oxygen. CPAP and PEEP are 10 centimeters of water. CPAP is set with a PEEP button. Okay, so BiPAP, don't confuse the two. So BiPAP is a bi-level setting, so we've got two different settings. So this is a positive airway pressure system. So we have a higher level during inspiration and a lower level during expiration. It's typically labeled IPAP and EPAP, and we'll look at these this summer. So IPAP is that inspiration, EPAP is that expiration. And then an example setting would be FiO2 40%, IPAP 10, EPAP 6. Okay. And then PEEP. I know I've said PEEP a whole bunch of times. So, okay. So PEEP is used to increase that functional residual capacity. But at high levels, this can decrease cardiac output and negatively impact our blood pressure. So remember at the beginning of this lecture, I said a normal pressure in our pleural cavities is 5, right? So most of the time, that's what we try to keep our PEEPs around whenever we intubate people. Now, when people have ARDS, COVID, things like that, that makes their lungs just extremely hard. Sometimes the PEEP has to go up because their lungs don't stay up as much or as good. So when we start getting into those high PEEPs, so above 10 centimeters of water, mercury, whatever you want to call it, we should be super, super cautious with these patients because it's a lot higher of a risk of causing those alveolar sacs to collapse. So when we're turning them, transferring, disconnecting, all those things, we just need to be mindful. And then exercise should be performed to patient tolerance. So it's been shown, and I have seen videos where they get people up walking, they still have a vent going and an ET tube in, and I'm just like, honey, if I'm ever on a vent, you ain't gonna see me up walking the halls with the tube down my throat. But, to each their own, and it really does help with getting them extubated quicker, and studies really do show that. So, yeah, I haven't really seen it implemented here yet, but just because I haven't doesn't mean that it isn't. The problem with really high PEEPs is that when we get too high, we start running the risks of pneumos as well. So, like with COVID, when everybody's PEEPs were 18, 20, 22. I think 22 is the highest we would ever go. But it was just a ticking time bomb on when their lungs were going to pop and we were going to be putting in double chest tubes. Because that pressure in that thoracic cavity can only sustain that for so long. So that's why we really, really, really try to keep their PEEP at about 5 to 8. Really less than 10 is where we try to keep people at unless we just absolutely can't. Okay. So these are settings. So a normal rate is going to be 12 to 20. FiO2 is going to be anywhere between 40 to 100. PEEP is going to be anywhere between 5 to 10. The sensitivity on the vent is going to depend based on respiratory and what the provider wants. And then our limits are going to be our minute volume, so how much volume we get every minute. And then tidal volume, I know I skipped over it. So tidal volume is, like I said earlier, based off of weight. So it's 5 to 7 mils per kg. So usually anywhere between 350 to 500 is where I have seen tidal volumes. And 500 is going to be like your upper range, like someone is really, really large. A normal tidal volume is usually about 350. 350 to 400-ish or so. But if you start getting tidal volumes too much, you're going to pop lungs as well. Because if you're giving somebody a lot more volume than they need that their lungs can take, if you're pushing that into their lung forcefully, then what do you think is going to happen? Probably ain't going to be too good. So, they, when my uncle was in the ICU, not here, not in Jonesboro, but they had, he's not a very large individual, but they had his tidal volume at like 750. My mom walked in and was like, his tidal volume's she was reading me vent settings, and she said 750, and I said 750? And she said, yeah, and I said, oh no. I was like, we need somebody in here right now because we're going to pop lungs, we're going to have double pneumos. And about that time, the pulmonologist walked in and I guess heard me and was like, absolutely agree with that. And he knocked it down. He was like, I don't know why it was ever that high to begin with. And I was just like, oh my God, we're going to have double pneumos happening over here and we're going to have problems. So anyway, it's based off of weight. If we get it too high, we can pop lungs. If we get it too low, then we may not be getting enough volume and oxygen to them. So that can also create problems. Okay, so this is just an example of what like a little vent setting would look like. So we've got our oxygen down here is at 35. Their PEEP is at 3. I do know that PEEPs have to be at 5 at least or lower to be able to extubate a patient, because remember 5 is that normal pressure in our lungs to begin with. So PEEP stands for positive end expiratory pressure. So it's the pressure in our lungs at the end of expiration. The respiratory rate is 12, and then that tidal volume is set at 450. Remember I said 350 to about 500 is about what I've seen. I may have seen 550 once, but I've never seen anything over a 500 and something. I've never seen a 6. Doesn't mean that it doesn't exist, but like I said, the patient that I had that was either 500 or 550 was like a almost 600-pound patient. So even patients that big, that's still the highest that I've ever seen. Okay. Now I've already talked about ventilator alarms a little bit. Remember, high pressure is that set above that peak airway pressure. So it's caused by decreased lung compliance, increased secretions, a bronchoconstriction, a kink in the circuit. Remember, high pressure, we've got pressure that's blocked that can't get through. So we're having a lot of pressure buildup. So it causes a high pressure alarm. Remember, low pressure is going to be, we've got not enough pressure going through. The vent is trying to push pressure out, but it can't push enough out. So it senses the pressure is low. So that can be from disconnections, cuff leaks, the patient can self-extubate or we extubated the patient. And then we've got an apnea alarm. So this happens when it's longer than 20 seconds without a breath. So if we've got a patient on a CPAP trial and they've got an apnea alarm going on and they stay apneic, they probably ain't going to pass their CPAP trial and we ain't going to extubate them and we need to put them back on a AC or SIMB or whatever vent setting they were on previously because they're going to stay on the vent. Low volume, so low tidal volume, low minute ventilation, patients just not receiving the volume that is set or needed. And then that high respiratory rate is breathing above the set rate. So this can be from pain or discomfort, air hunger, honestly anxiety when they're hyperventilating. If patients are awake and, we're trying to extubate them and maybe they're kind of coming around and they're just like, oh my God, what is happening? And they start freaking out, you're going to start seeing their respiratory rates go up a lot. And then a low gas source means that something has come disconnected from the wall, the vent circuit, something's just not connected where it needs to, and it's not getting the adequate oxygen that needs to be going. Okay. So minute ventilation, the ventilator usually supplies a calculated minute ventilation. It's respiratory rate times tidal volume. So we watch during therapy that the minute volume does not greatly increase. Like if the patient is on the vent or a CPAP, BiPAP, whatever it is, minute ventilation, if they're in therapy, that it doesn't increase. Mechanically ventilated patients routinely have a higher than normal minute ventilation, and it's because we have to meet their metabolic demands. So the minute ventilation is the amount of air a person breathes in a minute. It's calculated, like I said, by that tidal volume and a respiratory rate. So normal tidal volume of a person, like I said, is that 5 to 7, I think it was on the previous slide or so, 5 to 7 mils per kg or so. And it's actually the amount of air a person takes during each breath. So normal respiratory rate is 12 to 20-ish or so, give or take 14 to 18, 12 to 20, somewhere in the 12 to 20 range. So minute ventilation is tidal volume times respiratory rate. So if we have a 70 kilogram person and we've got a minute ventilation for a 70 kilogram person, would be 700. So we've got, let me put that in reverse. So say that we've got a 70 kilogram patient, okay? And our tidal volume is 5 to 7 kilograms. So we're going to do 70 times, we'll just do 7. That's going to be 490, okay, mils. So then let's just say we'll take a breath rate of 15. So 490 times 15 is 7,350. So milliliters. So a person requires a minimum of 6 to 8 liters of minute volume for the lung to be properly oxygenated. So basically that's just how you calculate the minute ventilation. And really respiratory is going to be the person that does this for you, and unless you just don't really have a respiratory therapist. But in an ICU setting, you're almost always going to have a respiratory therapist. I mainly was just walking you through an example of how that's calculated. Okay. So weaning, so we have a little mnemonic up here. So mentate, oxygenate, ventilate, and expectorate. There's really no one right way, either CPAP or a T-piece, if you're on a trach. Patients need to rest, and families need to understand that. Sometimes they really, really want to just, oh my gosh, you're awake, are you okay? And that overwhelms a patient and can tire them out because it's going to drive their anxiety up. They can't communicate. It's just a whole fiasco. So we really need to reinforce that patients need to rest to be able to adequately be weaned. So minimal stimulation, cluster care, things like that. And then a lot of the times, like unless there was an absolute necessary reason for it, I typically didn't really like anybody, like any more than 2 to 3 people to be in the room at a time. Really, if you can keep it limited to just the spouse. Small kids, unless it's an end-of-life care situation. I mean, I had a couple come up a couple of times just to see their parent and know that they were okay, but that's very traumatizing for a small child, too, to see their parent hooked up to that many tubes and lines, or grandma or grandpa, and they just can't comprehend what's going on. So I just reiterate that resting is needed to be able to adequately wean. And then we also obviously want to constantly monitor. It's a team approach. You've got to be involved. The provider's got to be involved. Respiratory's got to be involved. Therapy's usually involved. It's a very collaborative effort. Make sure we're following our orders and our protocols, and then make sure that our parameters are being followed. This says total volume 7 to 9. Honestly, anywhere between 5 to 10 is kind of the range that I've seen. 5 to 7, 7 to 9, all the way up to 10. Anywhere between 5 and 10, I think is technically appropriate. This is kind of an older PowerPoint that I haven't had a chance to redo, and I'm sorry. But 5 to 10 is kind of your normal. And like I said, respiratory is really going to be the one who's going to calculate this and stuff for you anyway. Okay. So we have what we call an ABCDE bundle, and sometimes F. And I'll post, there's another little 4 slide PowerPoint that I have that talks about this. So we have the ABCDE bundle. So A is awakening and breathing trial coordination, or A and B, awakening and breathing trial. C is the choice of sedation. D is daily delirium monitoring, and E is early exercise and mobility. So with A and B, A is awakening and breathing, and B is breathing, but we can also throw assessment in here. So we want to make sure that we're assessing our patient and preventing and managing pain, because that's going to make them harder to extubate. And then we want to do both spontaneous breathing trials and spontaneous awakening trials. So awakening and breathing trials daily to help measure when they are adequate and ready for extubation. Choice of sedation, so obviously light sedation when sedation is necessary. If we've got patients, we really want to avoid benzodiazepines when it comes to this, just because of all the side effects that it can cause. Precedex or dexmedetomidine is really nice if you can't get your patient completely off sedation, like propofol or fentanyl that requires an advanced airway. So if we use Precedex, sometimes it does let us have a little bit, it helps us keep our patient calm enough to help them pass a breathing trial to get them extubated. Then we also want to monitor for delirium. So with this, you're going to see those routine CAM ICU assessments. So these are going to be, or these assessments are going to help us make sure that the patient's not just completely out of it, because once you're intubated, sedated, you lose track of all time. Patients can easily become confused, and it's important for us to intervene in that if we can detect that and assess for that early. I kind of talked about early exercise and mobility earlier. The earlier we get them up and at it and working, the easier it usually is to extubate them, because their body's having to actually do some work. And then the F I'll throw in here now. So it's family engagement. So it is important to obviously have the family engaged and have the family supporting the patient and helping empower them to, stay calm, reassure them, and just be a support for them. All right, so extubation. So our nursing responsibilities for extubation are going to include a patient assessment, helping with the procedure, and then post-extubation care. So we want to make sure that that the head of the bed is 75 degrees. We've hyperoxygenated and suctioned them prior. We've suctioned their oral cavity. Most of the time, respiratory is going to be the one to fully extubate. You're just going to be there ready to suction, because they're probably going to cough up a bunch of gunk. They're going to deflate the cuff, and then they're going to pull it. We're going to help or encourage them to cough. and then we're going to suction as needed. Most of the time, they're going to gag, and they're probably going to cough up a bunch of gunk. Monitor them closely, encourage them to really rest their voice for 4 to 8 hours, because everything's probably going to be a little irritated, swollen, inflamed, and all that good stuff. And then we want to monitor their ability to cough and swallow. So after we extubate patients, they do not get anything to eat or drink until they have passed a swallow test or a swallow study at bedside. There should be a standing order in most ICUs is to perform a nursing bedside swallow. If they don't pass it, they don't get anything, and you call and consult speech. And speech comes to evaluate them, because sometimes they need a little bit of a modified diet afterwards, but if we just let them start eating and drinking after, they're going to aspirate, and we're going to be intubating right again because they're going to have aspiration pneumonia and be in respiratory failure. So, all right. I'm going to skip through this because Mr. Harmon's PowerPoint YouTube video kind of, it covers this a lot more than I'm going to, and he does a lot better of a job. Okay, so when we're talking about improving resistance and compliance, interventions to help decrease airway resistance, so we're going to do bronchodilators or steroids for bronchospasms. And once again, usually respiratory is the person to administer these, and you can give them straight through the vent, and it's really nice. You can also give them straight through BiPAPs as well. We want to reposition and suction to help mobilize and aspirate secretions, so we should be turning them every 2 hours or so. We want to use as short of tube as possible, and then decrease endotracheal tube resistance. Interventions to help improve lung compliance include help taking deep breaths and holding it, incentive spirometry. This is after extubation, but I'm also talking about things we can do all of these during intubation as well. To improve lung compliance, so like after extubation, we can have them deep breath and hold, use that incentive spirometry. We want to have them do about 10 breaths per hour. Prevent abdominal distensions, make sure they're going to the bathroom. Thoracentesis or chest tubes for pleural effusions if necessary, diuretics for pulmonary edema, and then of course if they have pneumonia, make sure that they're on the appropriate antibiotics. Okay, so hemodynamic effects of mechanical ventilation. So we typically have a decreased venous return, our pulmonary capillary compression, or we have pulmonary capillary compression and an increased right ventricular afterload, and then a decreased right ventricular stroke volume and a decreased left ventricular afterload. Complications can include barotrauma, which is just caused by excess pressure. So like I was saying earlier, when we get PEEPs too high, we can start popping lungs. So that's excess pressure. Because all that pressure in that thoracic cavity just eventually, the thoracic cavity can't handle it anymore. We can have volume trauma or volutrauma, which is caused by excessive volume. So remember those tidal volumes, I said if we get too high, we can have problems with that. We can start popping lungs that way too. We can have atelectrauma caused by low volume, resulting in repetitive opening and closing of the distal lung units or those alveoli sacs. So if we don't have enough volume going in, like I said earlier, we're not getting enough volume, we're not getting enough oxygen, so it's causing our body to do more work. And then biotrauma is caused by biochemical mediators released in response to mechanical ventilation, as opposed to mechanical complication. We can also develop infections, having a positive fluid balance or being fluid overloaded. Patients usually just discomfortable, and then psychosocial, because remember, they kind of get out of whack when it comes to their time orientation after they've been intubated and everything and sedated. Okay, benefits of sedation. So we use sedation to help reduce anxiety. Amnesia, particularly during the use of neuromuscular blocking agents. So this is going to be more of like your I'm literally losing my words today, you guys, and I'm so sorry. Paralytics. My goodness. I'll get there eventually. I was thinking Vecuronium, and I'm thinking paralytics. Lord. Okay. So amnesia, we want to induce amnesia when we use these neuromuscular blocking agents because you're paralyzed, and you never paralyze somebody without having sedation, because that is legit cruel and inhumane. So whenever you're intubating somebody, always sedate them before you paralyze them. Remember, sedate before you paralyze. This helps to also prevent recall of unpleasant experiences, decreases the level of stress hormones, reduces tissue oxygen consumption, so they're not having to work as hard, so their body's not consuming as much oxygen in their tissues. Helps to improve compliance with that ventilator, and then we give them just some sedation holidays to let their bodies rest. Okay, and I've kind of already talked about prevention of VAP. That's just in here again. So make sure the head of the bed's elevated, hand hygiene, really only suction when necessary. Most places require at least every 2 hours. Ventilator circuit changes when soiled, or they do get changed weekly. So either soiled, or if like their inline suction has a break in the cover, we replace it then as well. Okay. And then we want to avoid nasal intubations, extubate as soon as possible, discontinue NG tubes as soon as possible. Hold tube feedings if residuals are greater than 150. So this is going to kind of be dependent on facilities too, because I have worked at places where if it's greater than 200 to hold it, but also if it's greater than 100 to hold it. So it's just going to kind of be dependent upon the facility, but rule of thumb is about 150. And then we always want to use subglottic suctioning prior to repositioning or deflating a cuff. So there's a little thing that can hook up to, it's like a little tube or port that comes off of your main ET tube, and it's called a subglottic suction tube. So you literally can hook it up to suction, and it suctions that subglottic and helps get all that gunk out. Okay, I know that was a lot, and this was an hour and a half, but hopefully that helped cover the majority of things. We'll hit the high points on Monday, and I will post Mr. Harmon's YouTube video as well, and we'll go everything Monday. I'll see y'all then. Have a good weekend.